Welcome to Chapter 8, Joints, Part 2 of 2. As you saw in Part 1, we introduced joints, the different classifications, and then we jumped into the general structure of synovial joints, movements allowed at synovial joints, as well as the 6 types. From here, we will focus solely on two primary examples of synovial joints, the knee joint and the shoulder joint. As you saw in Chapter 8, Part 1, we have many different types of synovial joints, but all of those different types do have general features such as a joint cavity that is filled with synovial fluid. We have articular cartilage covering the ends of the bones that come together to form that joint, as well as reinforcing ligaments. For the two joints that are bolded, the knee and shoulder joint, we will discuss them in great detail. For each of them, you need to know the bones that come together to form the joint, as well as some of the specific ligaments or muscles that stabilize the joints. We'll start with the knee joint, which also happens to be the largest and the most complex joint in the human body. We'll begin with what joints actually come together to form the knee joint. We will discuss what bones also articulate with each other. The first joint that is included in the knee joint cavity is known as the femoropatellar joint. Again, if you look at the name, you are able to figure out what bones articulate to form that joint. So we have the femur, or the bone of the thigh, and the patella. If you remember, on the distal end and the anterior side of the femur, we have the patellar surface. The patellar surface is a nice smooth plane which allows for the patella to course over during knee flexion and extension. Two more joints that contribute to the knee joint are the lateral and medial joint. These two joints are collectively known as the tibiofemoral joint, or the articulation between the tibia and the femur. Remember, the tibia is the more medial bone in the leg. It also happens to be the weight-bearing bone in the leg. The fibula, or the lateral bone, has no articulation to the femur. The medial and lateral joints, or the tibiofemoral joint, occur between the medial and lateral femoral condyles and the medial and lateral menisci of the tibia. Remember, a meniscus is a ring of fibrocartilage that is there to increase the congruity between the two bones and to provide depth and stability. This joint, the tibiofemoral joint, is a hinge joint, so it allows for movement or angular movement in one plane, flexion, extension, and a slight degree of rotation when the knee is partly flexed. So we often refer to the tibiofemoral joint as a modified hinge joint. The first thing that you should do with this image is orient yourself. So here we are looking at the right knee joint. One of the first things that you could do after you orient yourself is begin to identify certain structures or organs. Here we are looking at the femur, or the bone of the thigh, as it articulates with the patella, as well as the tibia. Again, the knee joint includes three separate joints that are enclosed in the same capsule. We are able to identify the articular cartilage covering the ends of the bones. We can see the joint cavity, which is filled with synovial fluid, as well as many reinforcing ligaments. From here, this is a lateral view, so we can see the lateral meniscus, or a portion of it. On this slide now, we are looking at a superior view of the right tibia. The patella and the femur, as well as the fibula, have been removed. From this view, you are able to see those rings or C-shaped rings of fibrocartilage, which are now known as the medial and lateral menisci. Here, covering the medial condyle on the tibia, is the medial meniscus. What would sit on top of that now is the medial femoral condyle to form the medial joint, which contributes to the tibiofemoral joint. On the opposite side now, we see the lateral meniscus, sitting on top of the lateral condyle of the tibia, which will articulate with the lateral condyle of the femur. Also included in this slide, we have several reinforcing ligaments of the joint, such as the ACL and the PCL. When looking at the capsule that surrounds the knee joint and its three joints, it's relatively thin and pretty much non-existent along the anterior surface, which is why we like the patella, which is contained in the quadriceps tendon, to further protect the knee joint from the anterior aspect. In addition to these reinforcing ligaments and the capsule, the muscle on the anterior thigh is known as the quadriceps. The quadriceps tendon will envelop the patella, but also give rise to three thin ligaments that course from the patella to the tibia. Coming from the quadriceps, we will have thin ligaments which are known as a retinacula or a retinaculum. And then eventually, these medial and lateral patellar retinacula will course into the patellar ligament. A ligament joins bone to bone. The patellar ligament will connect the patella to the tibial tuberosity of the tibia. A brief review on bursa. There are at least 12 known bursa found along the knee joint. Again, these bursa are going to be little sacs of fluid that are placed in areas where we have friction between bones, ligaments, tendons, and even muscles. If you have ever experienced bursitis, that is an inflammation of a bursa. Here we have an anterior view of the right knee, and if you're having a difficult time trying to orient yourself, some things that you want to look for. First is the patella. The patella lets you know that you are looking at the anterior side of the knee joint. Superior to the patella, we find the quadriceps muscle, or the quadriceps femoris muscle, on the anterior thigh. Looking distal to the patella now, we find the tibia, which is the medial bone of the leg, as well as the fibula. Remember, the fibula has no articulation with the femur. But what you should really take a moment to identify on this image is the retinacula. Again, retinacula are thin, broad ligaments coming from the quadriceps and contributing to the anterior side of the knee joint. Here we have the medial patellar retinacula, as well as the lateral patellar retinacula. Attaching the patella to the tibia, or the tibial tuberosity, is the patellar ligament. When looking at the knee joint, the four ligaments on this slide are the four most important ligaments. From them, you need to be able to identify them, as well as understand how they stabilize the knee joint and what movement they prevent. First, we have the fibular and tibial collateral ligaments. These may be referred to as the lateral and medial collateral ligaments, respectively. These ligaments will prevent the rotation of the tibia and the femur when the knee is extended, so they keep the bones aligned. The fibular or the lateral collateral ligament will attach the fibula to the femur. Again, this is a ligament. There is no bone-to-bone connection of the fibula and the femur. The tibial or the medial collateral ligament will attach the tibia to the femur. And two more ligaments. We have the anterior cruciate ligament, or the ACL, which you might be familiar with. Cruciate means to cross. On the next slide, we will see how the ACL forms a cross with the PCL. The ACL attaches to the anterior tibia and will prevent forward sliding of the tibia. So if you stack your two fists on top of each other and you slide the bottom one forward, that is the movement that the ACL prevents. The PCL now will attach to the posterior tibia. Again, if you stack your fists on top of each other, slide your top fist forward and the bottom fist backward. The PCL will prevent the backward sliding of the tibia and forward sliding of the femur. Here on this slide, again, we have two right knees. The image on the left is obviously a cartoon. The image on the right is a cadaveric specimen taken from a human. Some things that you should be able to identify, especially on the cartoon drawing, will be the lateral collateral ligament, the medial collateral ligament, the ACL, and the PCL. Here we have the patella reflected, so we are able to get a view inside of the knee joint. Again, the ACL will attach to the anterior tibia, and the PCL will be attached to the posterior tibia. The lateral collateral ligament is about the width of a pencil. It's very cord-like. It attaches the fibula to the femur. The medial or the tibial collateral ligament is much more broad, and it will attach the tibia to the femur. If you look at the cadaveric specimen now, you are able to see the ACL, a little bit of the PCL, definitely the lateral collateral ligament, and just a brief view of the tibial collateral ligament. It is most likely that you or someone that you know of has had a knee injury. Oftentimes, these ligaments that we've been discussing, like the collateral ligaments and the cruciate ligaments, are torn or they have minor tears in them. The menisci, or those little rings of fibrocartilage, are also susceptible to injury as well. But when looking at clinical correlations, the one that you absolutely need to know is called the unhappy triad. The unhappy triad means that three structures are injured. Usually this occurs from a lateral blow to an extended knee. So this is often seen in football players, soccer players, or basketball players who plant their foot and change direction quickly. The unhappy triad includes the three following structures: the tibial or the medial collateral ligament, the medial meniscus, and the anterior cruciate ligament or the ACL. Here we see a picture of a hockey puck making a lateral blow to the leg or to the knee joint. Again, the unhappy triad includes the three following structures: the ACL, the MCL, and the medial meniscus. Now we will begin to discuss again one of the four main synovial joints in the human body, known as the shoulder joint. It is often referred to as the glenohumeral joint because it is the articulation between the glenoid cavity on the scapula and the head of the humerus. This is the most freely moving joint in the body, but with that comes a lack of stability, which often leads to shoulder injuries. If you think about a golf ball resting on a tee, that is synonymous to the fit of the head of the humerus and the glenoid cavity. If you are looking at the cadaveric specimen in the image to the right, you are able to see the glenoid cavity and how small it is compared to the head of the humerus. Again, this articulation is covered by an articular capsule, but similar to the knee, it's very thin and also loose. There are also several ligaments as well as fibrocartilage associated with the shoulder joint to try to reinforce it and provide some sort of stability. The first is the glenoid labrum. The glenoid labrum is similar to the menisci in the knee joint in that it is a ring or a rim of fibrocartilage. If you are able to identify it on this slide, it is not the capsule. It simply surrounds the glenoid cavity, and what it does is it tries to deepen the socket or deepen the cavity with hopes that the head of the humerus will fit into it better. It's there to maintain congruency between the two bones. In addition to the labrum, we also have the coracohumeral ligament, which runs from the coracoid process on the scapula to the head of the humerus. We also have 3 glenohumeral ligaments coming from the glenoid cavity to the humerus. The 3 glenohumeral ligaments are present on the anterior, superior, and posterior aspect of the shoulder joint. The shoulder joint lacks stability along its inferior aspect, which is why oftentimes when a shoulder dislocates, it comes out and falls inferiorly because there is nothing there holding it up in the cavity. In addition to the labrum and the glenohumeral ligaments and the coracohumeral ligament, we also have what is known as the rotator cuff. The rotator cuff includes 4 muscles that form a cuff around the shoulder joint. We will revisit these muscles when we get into Chapter 10, the muscular system, but for now you simply need to be able to identify them on an image, as well as know that these 4 muscles are the ones that make up the rotator cuff. They are the subscapularis, the supraspinatus, the infraspinatus, and the teres minor muscle. I like to think of the mnemonic SITS, capital S, capital I, lowercase t, capital S. Subscapularis, infraspinatus, a lowercase t because it's teres minor. We also have a muscle in the body known as teres major, and that does not contribute to the rotator cuff. And then lastly, supraspinatus. Looking at this image, this is a right shoulder. So again, we have the bone of the arm known as the humerus. We have the scapula or the shoulder blade, and we also have the clavicle. This is a posterior view now, but we are able to see all 4 rotator cuff muscles. The supraspinatus muscle resides in the supraspinous fossa, or the depression above the spine on the scapula. Usually, if someone has tendinitis within the rotator cuff, it comes from this muscle. If you follow it, it has to dive underneath the acromioclavicular joint. That tiny space doesn't offer much room for this muscle to move about, which often leads to irritation and inflammation. We also have infraspinatus. The infraspinatus muscle lives in the infraspinous fossa, or the depression below the spine of the scapula. We also have teres minor, contributing to the rotator cuff. And then on the anterior side of the humerus, we find the subscapularis muscle, which lives in the subscapular fossa on the anterior surface of the scapula as it abuts to the thoracic cage. Again, this was Chapter 8, Part 2, where we dove into 2 of the main synovial joints, the knee joint and the shoulder joint.